Hello, I'm Professor Stephanie Watson from the Save Sight Institute, the University of Sydney, and head of the corneal unit at the Sydney Eye Hospital. I'd like to welcome you to this lecture on decision-making in cataract surgery and ocular surface disease. In your cataract clinics, many patients might have ocular surface disease. Around 80% of patients coming for cataract surgery have been found to have a form of ocular surface disease. And over 50% don't even know that they have it, but have signs of dry eye disease. Dry eye disease is the most common ocular surface disease. Now, the reason we need to focus on ocular surface disease when we manage patients for cataract surgery is to optimize their outcomes. And that's to turn an eye that might look like this into something a bit clearer. Now, cataract surgery can have a number of effects on the ocular surface. Postoperatively, there's inflammation. The medications that are given afterwards may be preserved, and that can produce toxicity. When the cornea is entered through corneal wounds to remove the cataract, there can be changes in the corneal nerves from the incisions. And for some patients after surgery, they no longer need spectacles. It's also been thought that phototoxic damage may occur from the microscope light, and that betadine may have negative effects on the goblet cells. Just a little bit more about innovation in cataract surgery. Corneal incisions are very good for cataract surgery as they can be made self-sealing, but unfortunately they cut nerves. And it's been found that corneal sensitivity can decrease after cataract surgery, and this can affect the production of reflex tears and alter the sensation on the ocular surface. Topical medications. Now, this can cause toxicity. A preservative such as benzalkonium chloride can cause corneal epithelial cell apoptosis, and this causes damage on the ocular surface. Some topical medications can also cause an allergy, which produces further inflammation in addition to the cataract surgery. And it's now been thought that some topical medications may actually have an effect on the ocular microbiome, and this may further disturb the ocular surface. So what are ocular surface disorders? Well, they're really a diverse group of disorders that come from a range of causes. But the basic thing underlying all ocular surface disorders is that there's a failure of mechanisms that maintain the health of the ocular surface. And it can arise through any component of the ocular surface being affected. It may be the lids, the cornea, the conjunctiva, corneal innervation, tears. There are many causes. So when thinking about cataract surgery and making decisions, you could need to identify or define the ocular surface disease that might be there. And it's helpful to think about the patients you might see in your clinic in three ways. I'd like to introduce you to three patients that I saw in my cataract clinic this week, and I'll be talking more about them soon. Where to begin? Well, pre-operatively, you need to take ocular surface disease into account when you're doing your biometry. You may wish to consider having the surgical consult separate from biometry, and this can give you time to identify and manage ocular surface disease, and also manage the expectations of the patient. Then during the surgery and after the surgery, there are other considerations. So biometry, well, ocular surface disease can affect the tear film. And when you're trying to capture the keratometry, you may end up with distorted Myers, such as in these images here. You can see the impact of a bad tear film on the Myers. This means that your K readings can be unreliable. And you need to manage the ocular surface disease here as you would manage the patient prior to surgery. So here are the three patients that I saw: Miss S, Mrs. D, and Mr. E. Now, Miss C, her ocular surface disease was unmasked by the cataract surgery. Mrs. D, she didn't know she even had ocular surface disease. And Mr. E, he did have ocular surface disease, but it wasn't managed very well. So all of these patients required decision-making prior to their cataract surgery in regards to their ocular surface disease. And how do you approach it? Well, it's really a back to basics approach. Go back and start taking a history first. And this can be easily done with screening questionnaires, and they can be self-administered. but it's important to remember that the cataract can have an impact on vision. The Ocular Comfort Index is a questionnaire that doesn't depend on the vision, and so it can be good for cataract patients. In your history, think about risk factors. Does the patient wear contact lenses? This can be a risk for ocular surface disease. Glaucoma, and the risk here increases with the time that the patient has been on medications and the number of drops they're using. Do they have any systemic disease? Now, this is important for two reasons. One, the disease may be producing the ocular surface disease or associated with it, but also the treatment of systemic disease can worsen ocular surface disease. Sometimes patients with chronic pain syndrome may be more prone to neuropathic disorders of the cornea after cataract surgery. The medications to think about are all those anti-meds, antihypertensive, antidepressants. They're the most common ones that can produce or exacerbate ocular surface disease. So here's Mr. E. Now, he was a 78-year-old, nice gentleman. He had a history of shingles and hypertension. It was important to find out about that because if the shingles affected his ophthalmic division of the trigeminal nerve, he would be at risk of already having ocular surface disease. And for his hypertension, he might be on antihypertensive medications that are exacerbating it. He had cataracts and his eyes were gritty. He took amitriptyline and ACE inhibitors and had glaucoma. So he has a number of risk factors and things you might want to manage before his cataract surgery. This is an image of his cornea showing how distorted his tear film is. You can see the placido disc image here, quite distorted. It's going to be a challenge to get good biometry. So then after you've taken your history, the next thing to do is to perform an examination. You can have a look externally at their face for signs of rosacea, lid closure, and then move to the slit lamp. Look at the lid margins and their position. Is there any lag ophthalmos? This can be an important cause of discomfort, particularly in the morning. Eyelashes, is there any trochiasis? And what is the tear film like? And some basic assessments include looking at the tear film breakup time, which you can do manually on the slit lamp with fluorescein or non-invasively with some testing devices. The tear meniscus height can be recorded to give you an idea of aqueous production, and then look to see if there's any staining of the cornea and conjunctiva. In the images here, the top image, you can see some fluorescein staining on the cornea, and this patient had established dry eye. The middle side shows a normal-looking tear film meniscus height, and the bottom side is a scalloped image from a patient with Shahinian's sign, which is negative fluorescein staining or tear film breakup in recurrent corneal erosion. Okay, next on to the conjunctiva. Again, you're still on the slit lamp here, and have a good look for lid parallel conjunctival folds. They're kind of an early form of conjunctivochalasis and have been associated with dry eye. Is there any scarring of the conjunctiva or keratinization, symblephra, and signs of inflammation, such as infiltration, papillae, or follicles on the tarsal conjunctiva? Patients with limbal stem cell failure can particularly be at risk, and especially when preserved medications are given, so have a good look at the limbus. Look at the cornea. Are there filaments, thinning, infiltrates, keratinization, scarring, vascularization? These are all signs of ocular surface disease. It's worth paying special attention to the eyelids because many eyelid disorders affect the ocular surface. Blepharitis can produce inflammation. Ectropion and entropion can affect the lid position, as can lag ophthalmos, and floppy lid syndrome may be an unrecognized cause of a chronic papillary conjunctivitis. You then move on to determining what investigations you need. The Schirmer's is typically done without anesthesia. That's known as Schirmer's 1. You may want to check the corneal sensation and then assess the meibomian glands. Looking at how many glands are functioning versus blocked and the quality of the meibum. Tear film osmolality has been recommended by some, but sometimes can give variable results. Meibonography is a way of visually documenting the meibomian glands, and this can be good for patient education. Tear film interference and serology can be considered if you're wondering if the patient has an autoimmune disease or Sjogren's syndrome. Now, it's important to not miss some things, and this is toxicity. Always ask about medications, particularly if they're preserved. Never miss looking at the tear and assessing its health. Always look at the degree of inflammation and look at the lids. So back to our patients. Well, Miss C, she's 62 years old. She came for cataract surgery, and she did have a screening questionnaire beforehand, which indicated she didn't have dry eye. But post-op, she had irritation, and the ocular surface examination revealed a papillary conjunctivitis. So in our decision-making, we have to think, well, she probably had some propensity to ocular surface disease that's now been unmasked. And her trouble was she actually had a preservative allergy. So this was established through taking a history and examination. So putting it all together. So for your unmasked patient, you need to perform screening and look for risk factors. Sometimes you might find some clues that they're going to have ocular surface disease after the surgery. Unaware patients, your screening and risk factors will identify this group. And then once you find some sign of the type of ocular surface disease they have, you can do your examination and tailor investigations to make the diagnosis. So post-operatively, you need to repeat the assessments. And this is so you can identify any features of ocular surface disease that are still there and grade them so you can tell whether the patient's improving or not. You then follow the steps to manage the ocular surface disease and communicate to the patient what's happening. Grading the disease and identifying the features helps you communicate to the patient as to whether they're improving or not. Reassurance is important, as for most patients, their symptoms typically resolve. So back to Mrs. D. So screening for cataract surgery managed to pick up the fact that she had ocular surface disease. She was unaware. The survey found that she actually had dry eye symptoms. And then on biometry, I noticed that she had distorted Myers. She reported facial flushing, had reduced tear film breakup, and blocked meibomian glands. Using this information that she had meibomian gland disease before surgery allowed me to prepare her to get a good outcome afterwards. So cataract surgery and ocular surface disease. To sum up, you need to identify that it exists using a range of tools, or identify its grade. And it's a back to basics approach through a history, examination, and then targeted investigations. You need to document as you go along, both for your records, but to help educate the patient, as managing expectations is critical. Any ocular surface disease you find needs to be addressed. After your management, you need to reassess to ensure the patient's improving.